Assalamu alaikum and good afternoon. My name is Muhammad Asad Parvez. I'm a consultant oncoplastic breast surgeon at Shaukat Memorial Cancer Hospital and Research Center, Lahore, Pakistan. Being the chairman of the 21st Shaukat Cancer Symposium, it's my pleasure to welcome you all to the plenary session. After the last 2 years virtual symposia through the COVID-19 pandemic, we are delighted that now we are able to return to the physical meeting. This has been organized as a hybrid event where the option to attend in person or virtually through the online platforms exists. Shaukat Cancer Symposium is the largest oncology meeting in Pakistan. It is expected to attract over 3,000 delegates during these 3 days, attending in person here in Pearl Continental Hotel. And there are many others who will be joining, who have joined through the online platform. This meeting provides a platform to diverse delegates, including leading researchers, scientists, practitioners, and trainees from across the world to exchange knowledge and expertise related to cancer diagnosis, treatment, and research. This year, we have had a total of 146 invited speakers participating in our symposium, out of which 99 are international speakers from 19 different countries. From within Pakistan, we have 47 speakers presenting from most of the major hospitals and medical research institutions who share their experience and knowledge. This year, we have received a record number of 356 abstracts, covering all aspects of cancer care, from basic science research to day-to-day oncology and precision medicine. From amongst these, our abstract review committee performed a daunting task of selecting many to be presented as free papers and others as e-posters. The best 7 submissions will compete for the Hassan Rashid Memorial Gold Medal, named in honor of a great supporter and benefactor of our institution. This year, a new video presentation session has been introduced, where procedural videos are presented that compete for an award. This session was very well attended yesterday. Additionally, there will be Best Free Paper and Poster Awards. To acknowledge the cancer research carried out in Pakistan, Bashir Elawi Award was introduced last year. This is given to the best PubMed indexed cancer-related publication from Pakistan, published in the year 2021. To honor the memory of another supporter for Shaukat Memorial Trust, Begum Mir Nursing Paper Award has been introduced this year. We are eagerly awaiting for these awards to be announced tomorrow towards the end of Hassan Rashid Memorial Research Session. Many people have asked me whether are we going to announce these awards towards the end of today's session, and I have clarified that no, we always announce the awards and distribute the awards towards the end of Hassan Rashid Memorial Research Session on Sunday afternoon. Physicians, nurses, scientists, pharmacists, researchers, students, all are encouraged to spare time and participate in this high-profile academic activity. The symposium is accredited by the American Association of Continuing Medical Education, and participants can claim up to 34.25 credit hours. Please fill the online feedback forms on the symposium website within 2 weeks period in order to claim these hours. There is a CME evaluation button next to each session that needs to be clicked for this. At the end, I would like to thank everyone who has been involved in the preparations of the symposium. I'm grateful to the hospital senior management for trusting me 3rd time in a row with this responsibility. Our organizing and scientific committees provided us with all the support that was required, especially in making a strong, balanced scientific program with involvement of high-profile national and international speakers. Thank you to all our invited speakers that you have spared your valuable time for this academic activity. All clinicians and researchers who have submitted their abstracts are greatly acknowledged. Our IT department, under leadership of Mr. Idris Khokhar, has worked tirelessly to provide the virtual component for the seamless running of the parallel sessions. To name a few amongst these I would like to especially thank Mr. Hasib, Ms. Sana, and Ms. Bushra from IT department. Special thanks to all those who have been involved in the fantastic preparations here at the Pearl Continental Hotel, especially Farooq Adil Saab, Director Facilities Department. Marketing and business operation departments have helped us in making this symposium a word of mouth within Pakistan and abroad through their advertisement. Symposium Secretariat, especially Ms. Anika, has been the main workforce behind the scene, putting everything together. I'm really indebted to you. Thank you. Thanks to Mr. Nasir Salim and Farooq Gulsab and the rest of transport team for ensuring safe and efficient pick and drop of invited speakers from the airport. Finally, I would like to thank my co-chair, Dr. Kashif Sajjad, for his continued support. Next, it would be great honor for me to invite Dr. Muhammad Asim Yusuf as the next speaker in this plenary session. He really needs no introduction to our audience. Dr. Asim is Chief Medical Officer of the hospital. He has been the backbone of Shaukat Khanum Memorial Cancer Hospital and Research Center since its inception in 1994. He has led the institution through thick and thin. His personal mission towards improvement of cancer care in Pakistan is very much appreciated. He's currently out of country on official hospital duties, hence he's joining us online. Without further wait, I would hand over to Dr. Muhammad Asim Yusuf.
I know we have attendees from all over the world joining us today, so good morning, good day, good evening, depending on where you're joining us from today. It's a huge honor and a privilege for me to welcome you on behalf of the Shaukat Khanum Memorial Cancer Hospital and Research Center to the 21st Shaukat Khanum Memorial Cancer Symposium, being held this year once again in the historic and beautiful city of Lahore, as well as virtually in what is our first hybrid event. Many of you will be familiar with the first Shaukat Khanum Cancer Hospital, which opened in Lahore in December 1994. And again, many of you will have seen the second hospital, which opened in Peshawar in December 2015. We are currently constructing what will be our third and Pakistan's largest tertiary care cancer facility in Karachi, Sindh. The inspiration for the construction of the hospital in Lahore was the lady shown in the red circle, who was Shaukat Khanum. Shaukat Khanum succumbed to colon cancer in the mid-1980s. Her son, Imran Khan, shown to her right in this photograph, was inspired to build this hospital in her memory, but also particularly because of the suffering he had seen amongst the hundreds or perhaps thousands of other patients he encountered as he accompanied his mother through her cancer journey, who were less fortunate than she was and who were unable to access cancer care because they were unable to afford it. And it was really the hundreds or thousands of such patients who formed the other main inspiration for him to want to make this hospital. Our mission statement was and remains as shown in the slide. I'm going to highlight the salient features of this just to show you the key elements. We aim to act as a model institution to show that it is possible to achieve excellence in Pakistan, that this is not an alien concept possible only in the West. We are, of course, a cancer hospital. Perhaps the most important part of our mission statement is in the fourth line, which says that this is done irrespective of the patient's ability to pay. So once a patient is accepted for treatment, all diagnostic facilities, all treatment facilities are provided without regard to whether the patient is able to pay for their care or someone else is paying for them. Latterly, we have a role in education of healthcare professionals and the public, and of course we perform research into causes and concepts. Pakistan is a large country with a large population, a relatively low GDP. We rank much lower than we would like to on the Human Development Index, and we have low public sector spending on health. There is a heavy cancer burden in the country, and It is estimated that there are upwards of 175,000 new cancer cases in Pakistan each year. Because of the advanced stage at which a large proportion of these patients present, there are between 60 and 120,000 cancer deaths in Pakistan each year. So at the current time, we have 3 hospitals in Peshawar, in the northwest, in Lahore in the east, and the new hospital being built in Karachi in the south. We also have diagnostic centers in Lahore and in Karachi. We have walk-in clinics where in Lahore, Peshawar, and Karachi, which form the main portal of entry for most patients coming to the hospital. Anyone with a diagnosis or a suspicion of cancer can go to one of these clinics, be seen the same day, be evaluated, and be assessed to see if they can be accepted according to our acceptance criteria. Finally, we have this network of laboratory collection centers all across the country, where anyone can go and have lab tests done on payment, knowing that they will get a first-class, high-quality lab test performed and reported, but also that through paying for such tests, they are contributing to the care of those less fortunate than themselves and allowing for supported cancer treatment. Our core values have always been quality and equality. We aim for equal treatment for everyone in everything that we do, whether this be access, which relates to acceptance into the system, and this is based on disease and stage, not on financial wherewithal, which also encompasses all our clinical facilities so that all patients get exactly the same investigations and diagnostic tests, they're seen by the same doctors, they get the same treatments and the same chemotherapy. And it also encompasses what we call the hotel facilities or the softer side of care. All patients are in 2-bed inpatient groups. It's not uncommon for a patient who's paying for themselves to be in bed next to someone else in the next bed who is being supported in their treatment. We have consistently maintained this statistic wherein we treated more than 75% of all cancer patients seen at the hospital each year completely free of charge. And in this time, we've spent over $586 million in philanthropic spending to support this effort. Now, we're a cancer hospital, so obviously most of the clinical departments are very cancer-centric. Nursing forms the bedrock of clinical care, and we work continuously to help promote the image and the stature of nursing in Pakistan. Just a summary slide to show clinical activity over the last year, for which we have full data, 2021. 12,000 plus new cancer patients have been registered at the 2 hospitals in this time. Close to 250,000 outpatient visits, 63,000 chemotherapy sessions, 19,000 surgical procedures, 78,000 radiotherapy sessions, and a very large number of lab tests, reflecting the fact that this is not only within the hospital, but also within the laboratory collection center network. We have always invested heavily in order to remain at the cutting edge of technology, and to this end, in Lahore, this year we installed our second TrueBeam linear accelerator. We've also installed and instituted next generation sequencing systems so as to optimize cancer diagnosis and treatment. In Peshawar, our linear accelerators have been upgraded with home beam CT facilities, and we've also expanded and developed our surgical facility further with the construction and commissioning of 2 new operating units in Peshawar at the hospital there. We have an entirely electronic hospital management information system. This was developed in-house. It ensures uniformity and accessibility at all times, and it's used across all our facilities, our hospitals, diagnostic centers, and all our laboratory collection centers. In addition, we have also provided this for free to a number of large public sector teaching hospitals, both in Punjab and in the KPK. Quality forms the bedrock of everything we do. In April 2018, we became the 3rd hospital in Pakistan, here in Lahore, to obtain Joint Commission International accreditation, and our hospital in Peshawar followed suit just a year later, becoming the 4th hospital in Pakistan to achieve this recognition. Earlier this year, the Joint Commission instituted a new program called Enterprise Accreditation. This was ideally suited for organizations such as ours, which have a footprint across multiple geographic locations. And as a part of this process, our 3 facilities shown here in Shaukat, Lahore, and our Diagnostic and Treatment Center in Karachi, as well as our other diagnostic centers in Lahore, were all surveyed simultaneously by a team of very senior surveyors from the Joint Commission in August and September this year. And I'm proud to tell you that we became, mashallah, only the 2nd organization in the world to achieve enterprise accreditation from the Joint Commission in September 2023, September 2022, sorry. We are also obviously committed to maintaining standards of quality in other spheres of activity. We're of course bound by the dictates of all our local regulators, the provincial healthcare commissions. We have ISO certification in a number of areas, including the ISO 22000 certification for our food services, and we're also part of the College of American Pathologists quality certification program. Our hospital in Lahore has been accredited by the American Society of Health System Pharmacists for a number of years now. We are one of only 2 non-US programs accredited by the ASHP in this way. And earlier this year, our Shaukat Hospital has also now been accredited by the ASHP. We, of course, have a role in education and training of medical staff, as well as other healthcare professionals. This is not a a comprehensive list of training programs, but it's just a spectrum to show that virtually all our junior doctors at both institutions are enrolled in formal training programs of the College of Physicians and Surgeons of Pakistan. And of course, we also run education and training programs for nursing and other allied health staff. Most of these are diploma programs, but we're especially proud of the fact that we now have a bachelor's degree in nursing, which commenced in 2020. And it's a great tribute to our nursing colleagues that they've been able to commence this program and keep it running through the pandemic. We have a role in education public, and of course we were pioneers in developing programs to raise awareness about breast cancer in Pakistan, which is the commonest tumor in women in our country, and which affects women at a younger age than it does in the West. Each year we lead a very public, high visibility national campaign to ensure that women are able to come forward and to talk about this disease, something that was not possible 25 to 30 years ago, and to seek help at the first sign of the problem. Finally, we are a research centre. We perform research into the causes and treatment of cancer in Pakistan. This encompasses both basic science as well as clinical research. We have an institutional review board to ensure that the highest ethical standards are adhered to throughout in all our research activities, and that the rights of the human subject are always protected. We have a hospital-based cancer registry, as well as Pakistan's largest population-based cancer registry, which is called the Punjab Cancer Registry, which is supported by and run by Shaukat Khanum, with the aid and collaboration of most major teaching hospitals throughout the Punjab and many of the leading private laboratories in addition, to all of whom we're immensely grateful. Over the last 28 years, we have over 850 peer-reviewed publications from our institutions. And as a result, we are again in 2022 at the top of the league table in oncology publications from Pakistan. Coming now to the symposium, the Shaukat Cancer Symposium has now become the de facto national cancer meeting in Pakistan. We started with relatively humble origins in 1993, a year before the hospital opened, and this is not a great photograph, and I'm not sure how well it's going to project, but you may be able to recognize a somewhat younger Dr. Noshaban Berki at the podium there. Until 2009, the symposium was held biennially. And since then, it's been held annually. The wealth of historic and natural beauty in our country has meant that we have never been short of terrific images for our symposium posters, as you'll see here in this collage. Looking to the future, we aim to increase Pakistan's capacity to treat cancer. We're doing this by developing a new clinical building at our Lahore hospital, which will, inshallah, double our clinical capacity at Lahore over the next 3 to 4 years. I've talked briefly about the third hospital in Karachi. This is our third Shaukat Khanum Memorial Cancer Hospital and will be Pakistan's largest tertiary care cancer facility. It's going to be twice the size of the hospital here in Lahore. Appropriately, since it will serve not only Karachi, which is Pakistan's largest city and our economic hub, but it will also serve patients from all over the Sindh province, as well as southern Balochistan. And this is a relatively recent photograph showing the construction work continuing at full steam. The grey structure is virtually complete. The main hospital building on the left of the image, and the car parking building here at the bottom right. It's expected that the hospital will, inshallah, be completed and open its doors to the public at the end of December 2023. As I said, it's going to be Pakistan's largest cancer treatment facility, and just one aspect of that is the very large number of radiation bunkers, 10 in all, which you see in the back of the building there, to be constructed and are complete. Like our hospitals in Lahore and Peshawar, this will be a complete tertiary care cancer centre, complete with cutting-edge diagnostic and therapeutic equipment and technology, staffed by highly trained and experienced clinicians, and able to deliver all aspects of clinical care for cancer when it opens, inshallah, in December next year, as I've said. Now, how do we pay for all this? Well, hospital revenue accounts for about 44% of our budget. Zakat, which is a tax that Muslims pay on their saving each year, is a quarter of the budget, and non-zakat donations account for about a third. Geographically, where does the money come from? Well, 43% of it comes from overseas, which is largely from the Pakistani diaspora, while the remaining 57% is from domestic sources. Revenue from the hospital's diagnostic services is utilised for expansion projects and construction and so forth. Zakat, on the other hand, is utilised only for direct patient care. It's not invested or saved for a rainy day. It's not used for construction, but is only used for direct patient care and is utilised in its entirety in the year that it is collected. For this year, we have a budget of $135 million to allow us to continue to treat an ever-increasing number of cancer patients free of charge, but also to continue work on our expansion projects. And of this, $110 million will, inshallah, be coming from zakat and donations. So I'd like to thank you for your attention. Thank you for joining us once again for the Shaukat Khanum Cancer Symposium. It's all of you that make it a success, and we look forward to seeing it grow further with you in the years to come. Thank you.
Ladies and gentlemen, it is my distinct honor and privilege to invite the plenary speaker of the 21st Shaukat Khanum Cancer Symposium to join us. Professor Monica Morrow really needs no introduction to an audience of surgeons and oncologists. After graduating from Jefferson Medical College in Philadelphia in 1976, she completed her residency in University of Vermont Medical Center. Since 2008, Professor Morrow has been the Chief of Breast Surgery Services at Memorial Sloan Kettering Cancer Center, New York. She has also been the ex-president of the Society of Surgical Oncology in USA. Professor Morrow is an international authority on breast cancer surgery and is the recipient of multiple international awards and honors, including over 500 peer-reviewed publications. Professor Morrow has been named one of the top 20 most powerful women in healthcare in USA. Without further delay, I shall hand over to Professor Monica Morrow.
Monica Morrow, Chief of the Breast Service at Memorial Sloan Kettering Cancer Center. I appreciate the opportunity to give this plenary lecture at your meeting, and I'm sorry I couldn't be there in person with you. These are my disclosures. So the surgical therapy of breast cancer has evolved dramatically from the time of radical mastectomy to everyone through modified radical mastectomy, which really opened the door to what we do today, which is offer patients a choice of breast conservation with or without immediate breast reconstruction, and even more limited forms of mastectomy, such as nipple-sparing mastectomy. Treatment of the axilla has seen similar progress from routine 3-level dissection with axillary irradiation to more conservative dissections to the era of sentinel lymph node biopsy, initially for staging, then for therapy in patients with limited amounts of nodal disease. So what has been the impetus for the de-escalation of surgical therapy? And there are several things that happened. First, the increased uptake of screening mammography and improved awareness of patients about breast cancer have resulted in the diagnosis of smaller cancers with lower nodal disease burdens. Perhaps more importantly, however, is we now recognize the importance of both tumor biology and systemic therapy in local control. And that has allowed us to finally accept the idea that bigger surgery does not cure bad biology. And if we look at what that means in terms of surgery, we all recognize that molecular breast cancer subtype, as approximated by ER/PR and HER2 status, is associated with significant differences in prognosis, so that luminal A tumors, ER/PR positive, HER2 negative, have much better survival outcomes than triple negative breast cancers or basal tumors shown here in the orange. However, if we look at local recurrence, we see a very similar pattern. These graphs are comparing local recurrence in triple negative cancers to non-triple negative cancers. And you see that for the non-triple negative cancers treated with breast conservation, the relative risk of recurrence is half that of the triple negative cancers. The fact that this is a biologic principle and not a matter of tumor burden is illustrated in the mastectomy graph, where we see basically the same thing, a 44% reduction in local recurrence in the non-triple negative cancers. And this is such a fundamental property of breast cancer that if we look at the very smallest breast cancers we can find, tumors a centimeter or less in size, we see the same pattern. Triple negative cancers shown here in the green line with the highest risk of local regional recurrence, luminal cancers shown in the pink and the black line with the lowest risk. So biology matters not only in terms of metastatic disease, but local therapy outcomes. If we also look at the impact of systemic therapy on local treatment outcomes, we see that this is very important. From the Oxford Overview analysis, giving 5 years of tamoxifen compared to placebo cuts in half local recurrence, but better systemic therapies such as aromatase inhibitors or switching strategies have a further benefit of 20 to 50%. This benefit is not limited to endocrine therapy. If we compare chemotherapy to none, we see a 40% reduction in local recurrence. And in HER2 overexpressing cancers, the addition of trastuzumab to chemotherapy results in a further 50% reduction in local regional recurrence. So if we look at what this means from a practical point of view, this is illustrated in these two retrospective studies from Memorial, where we looked at HER2 overexpressing cancers being treated with breast-conserving surgery. And for the years immediately prior to the approval of adjuvant trastuzumab, you can see that the 3-year local regional recurrence was 7%. After trastuzumab became routine as an adjuvant therapy, in spite of the fact that there were the same surgeons and the same radiation oncologists, local regional recurrence fell to 1%. If we look at a more heterogeneous group of mastectomy patients, T1 to T3, node negative, node positive, treated with or without radiotherapy, we see the same pattern. Prior to trastuzumab, 5-year local regional recurrence rates of 6.6%, after trastuzumab, 1.5%. And we see this illustrated very nicely in this study, which looked at some 86,600 women who were treated in phase 3 randomized trials of adjuvant therapy. During the time period from 1985 to 2010, local regional recurrence fell from 30% to 15% of all recurrences. And you see that that was observed for patients treated with chemotherapy, shown in the blue line, as well as those treated with endocrine therapy, shown in the green line. Now, another reason we have been able to improve the surgical therapy of breast cancer is by adopting a true multidisciplinary approach to treatment rather than the sequential use of chemotherapies. And the sequential use of different therapies. This allows us to leverage the benefit of systemic therapy and radiotherapy to decrease the extent of surgery and therefore its associated morbidity. And neoadjuvant chemotherapy is perhaps the classic example of this. So when we look at what has gone on in breast cancer therapy in recent years, early on in treatment of the breast, we had the major shifts of the adoption of breast conservation and immediate reconstruction. More recently, skin-sparing and nipple-sparing mastectomies, broadened indications for breast conservation, and the use of neoadjuvant therapy to downstage to breast conservation. In the axilla, sentinel node biopsy for axillary staging was the first real change, but now sentinel node biopsy with or without radiotherapy as treatment, and in the post-neoadjuvant chemotherapy setting, to downstage node positive to node negative patients represent major paradigm shifts. And so if you wanted to look for a unifying theme of the changes in breast cancer management that have occurred over the past 20 to 30 years, I would say that what I call intelligent de-escalation, based on evidence that systemic therapy and radiotherapy control subclinical microscopic disease in both the breast and the axilla, is the theme that we're seeing here. So let's look at some practical examples. This is a study that we did using a population-based sample of 800 women who were attempting initial breast conserving surgery. And although we are very good at picking women who can have breast conservation, 88% of them were ultimately successful. Notice that re-excision rates were high at 22%, and about 12% of patients were converted to mastectomy. So overall, fully a third of patients underwent 2 surgeries. And it was this observation that led us to re-examine the question of what is an adequate margin for breast conserving surgery in light of the changes in our thinking that I just showed you. Now, key points in this re-examination were the fact that we recognize that a negative margin does not imply that there is no residual tumor in the breast, and that the only microscopic margin in the original randomized trials of breast conservation versus mastectomy was no ink on tumor in the NSABP B06. Other studies, widely perceived as having more widely clear margins, in fact, only required gross margins. So to address this question, the Society of Surgical Oncology, along with ASTRO and ASCO, put together a multidisciplinary consensus panel, and we performed a meta-analysis, which was of all retrospective studies to address the question of the relationship between local recurrence and margin width. And as illustrated here, using 2 different statistical tests, we found no difference in the likelihood of local recurrence when a margin was 1 millimeter, 2 millimeters, or 5 millimeters, which led us to conclude that while negative margins of no ink on tumor optimize local control compared to positive margins, that more widely clear margins do not significantly improve local control, and the routine practice of obtaining margins more widely clear than no ink on tumor is not indicated. So what has happened as a result of that consensus? Well, this is a population-based study that we did examining changes in re-excision rates in 2,500 women treated before and after that consensus was developed. So graphed on the x-axis is time. The months that are in pink are the months when that consensus was disseminated at meetings and ultimately published. So this is the pre-consensus period in 2013, the post-consensus period here. And what you see is that although patient tumor characteristics did not differ, over that time period, rates of re-excision shown in the blue fell dramatically, and conversions to mastectomy in patients attempting breast conservation also decreased. So if we compare the beginning of that study, April 2013, to the end, April 2015, we see that rates of breast conservation rose from 52% to 65%. Unilateral mastectomies fell from 27% to 18%, and bilateral mastectomies also significantly decreased. Since that time, there has been a meta-analysis that we reported looking at 30 studies, almost 600,000 patients, and looking at the impact of treatment before and after the consensus on re-excision rates. In the 17 institution-based studies, there was about a 40% decrease in re-excision, and in the 5 population-based studies, one of which was the study that I just showed you, there was a 25% decrease. So this is an example of de-escalation of surgery based on the fact that we know these patients are going to be receiving radiotherapy, and in the vast majority of cases, systemic therapy, all of which will contribute to local control. So what about the axilla? And here changes, if anything, have been more dramatic than what we've seen in the breast. We recognize that axillary dissection is associated with significant morbidity, particularly lymphedema, which occurs in at least 25% of patients. With sentinel node biopsy alone, the rate of lymphedema is markedly decreased. So the question today is, when do we need to do axillary dissection? Again, we're dealing with smaller cancers with lower nodal disease burden. In today's world, the number of involved lymph nodes rarely determines the type of adjuvant systemic therapy, and we know that node-positive patients will receive systemic therapy and radiotherapy. So can we decrease the extent of surgery? And that, of course, was the question asked by these 4 prospective randomized trials summarized on this study, all of which used sentinel node biopsy alone or in combination with radiotherapy compared to a control arm of axillary dissection. And what you see is that at 10 years of follow-up, local control after sentinel node biopsy alone is excellent, 2% or less, after sentinel node biopsy with radiotherapy, 2% or less, and that there is no difference in disease-free or overall survival compared to patients undergoing axillary dissection. Now notice that these are overwhelmingly trials of patients with metastases in 1 or 2 sentinel nodes, not with heavier tumor burdens. So what we can conclude is that axillary recurrence is seen in fewer than 2% of patients after sentinel node biopsy with or without radiotherapy, even though 13 to 39% of patients randomized to the axillary dissection arm had additional metastasis. This disease is controlled with systemic therapy and radiotherapy. In all of these studies, nodal recurrence was an early event. It usually occurred before 5 years. And this approach applies to patients with metastases in 1 or 2 sentinel nodes. So axillary dissection can no longer be considered standard for patients meeting study eligibility criteria. And if we look at how this has changed our practice, this is a study we did at Memorial of 793 patients who met the ACOSOG Z11 eligibility criteria, meaning they had T1 or T2 tumors, clinically node negative, and were undergoing breast conservation, all had positive sentinel nodes, And you can see that we were able to avoid axillary dissection in 84%. The primary reason for axillary dissection was metastases in 3 or more sentinel nodes or gross extracapsular extension, meaning matted nodes. And if we look at the outcome of this patient cohort reported here at a median follow-up of 37 months, you see that whether patients were treated with conventional radiation tangents in the supine position or treated prone, so their axilla received essentially no radiation, or treated with nodal RT, as was done in 21% of cases, that the likelihood of any nodal failure was less than 1.5%, duplicating the results seen in ACOSOG Z11 and Amoros. Now, we also looked at so-called high-risk patients because when this practice change initially came about, there was a lot of anxiety about applying this to women other than postmenopausal hormone receptor positive women. So here we defined high-risk women as those under the age of 50 or with HER2 overexpressing or triple negative breast cancers. You can see there were 288 of those patients. The rate of needing axillary dissection in that group was 16%. And in the women age 50 and older who were ER positive, it was 17%, not different. And in those patients who had axillary dissection, the extent of nodal disease did not differ between these two groups. So at this point in time, I would say it's quite uncontroversial that patients undergoing breast conservation who meet these criteria do not need axillary dissection. But what about mastectomy patients? How do we decelerate therapy in mastectomy patients? And if you look at those with macrometastases, in Amoros and Odoasar, mastectomy patients were included, but they only made up 17% and 14% of the study populations, so that there were a total of 151 patients in these two trials combined who were treated with a mastectomy, a sentinel node biopsy, and radiotherapy, and there was no separate analysis of the mastectomy cohorts. So when can axillary dissection be avoided in node-positive mastectomy patients? Well, we accept the fact that axillary dissection is not indicated for those with micrometastases, regardless of the breast operation, because we know the associated tumor burden is low. In addition, if you have someone who has macrometastases in 1 or 2 sentinel nodes, and you know, based on either the presence of those sentinel node metastases or other patient and tumor characteristics, that post-mastectomy radiotherapy is indicated, then axillary dissection can also be avoided because now that patient looks just like breast conservation patients in Amoros or Odoasar and patients undergoing mastectomy and radiotherapy in the old NSABP B04 trial. Now, one of the difficulties with applying this is that criteria for post-mastectomy radiotherapy are not well standardized. What I am showing you here are the criteria that we have adopted at Memorial. And you can see that we have some risk factors that are considered high risk factors, very young age, triple negative cancer, extensive lymphovascular invasion, and other risk factors based on the trials of post-mastectomy radiotherapy. Any patient with metastases in 3 or more sentinel nodes gets an axillary dissection and gets post-mastectomy radiotherapy. Whether or not post-mastectomy radiotherapy is given to those with 1 or 2 nodal metastases depends on the number of risk factors they have. So what should be apparent from this is that some of these risk factors can be identified preoperatively, but not all of them. So our goal is to minimize the combination of axillary dissection and nodal irradiation because that's associated with significantly increased risk of lymphedema. So we looked at a retrospective group of patients and said, if we stop doing frozen section on mastectomy cases, how often would we avoid axillary dissection, and how many patients would we have to take back to the operating room? So in this consecutive series of T1 to T3 clinically node-negative patients undergoing upfront mastectomy, axillary dissection was avoided in 94%. 87% of those patients had either no nodal metastases or micrometastases only, and another 132 had metastases in 1 or 2 sentinel nodes, but had an indication for post-mastectomy radiotherapy. Axillary dissection was necessary in 6% of cases. Only 44 patients had metastases in 3 or more sentinel nodes, making the point that clinically node-negative patients rarely have very heavy nodal tumor burden. In another 73 or 4% of the whole group, there were not clear indications for post-mastectomy radiotherapy based on metastases in 1 or 2 sentinel nodes, so they underwent axillary dissection to see whether or not that would be necessary. So the net result here is that we were able to avoid axillary dissection in 53% of node-positive patients undergoing mastectomy. Now, an unanswered question is whether or not radiotherapy is really necessary to avoid axillary dissection in mastectomy patients, because not all node-positive patients get radiotherapy. And there are 2 trials that will provide definitive answers to that question. One is the POSNOC trial in the UK, which is closed to accrual, in which patients with metastases in 1 or 2 sentinel node macrometastases undergoing breast conservation or mastectomy are randomized to no axillary treatment other than a sentinel node biopsy or a control arm of axillary dissection or axillary radiation with an endpoint of axillary recurrence. The CENIMAC trial in Europe is still recruiting patients. It allows somewhat larger tumors up to T3, again, 1 or 2 sentinel node macrometastases, randomization to a control arm of axillary dissection, experimental arm, no axillary treatment other than sentinel node biopsy with an endpoint of breast cancer specific survival. So these 2 studies will provide us with definitive information on how important radiating the axillary nodes is to local control and survival in patients with limited nodal burden in the axilla. So now to change gears a little bit and talk about neoadjuvant chemotherapy. Initially, neoadjuvant chemotherapy was used to convert inoperable disease to operability. But as it's become apparent that it can be used for downstaging for breast conservation and downstaging the axilla, its use in all subtypes of breast cancer has continued to increase. So neoadjuvant chemotherapy is ideal for de-escalation because in the upfront surgical setting, you're relying upon systemic therapy and radiation to kill subclinical disease, but you haven't given that treatment yet, so you don't know if it works, and you can only determine if it has by looking at long-term outcomes such as local recurrence-free survival, disease-free survival, and overall survival. Neoadjuvant chemotherapy, in contrast, offers the opportunity to identify responders prior to surgery, allowing less local therapy in those with a good response and more local therapy in those who have a poor response. So if we look at conversion to breast-conserving surgery with neoadjuvant chemotherapy in patients with tumors too big for breast conservation, this is a series we reported of 600 women with large tumor size relative to their breast size who underwent neoadjuvant chemotherapy. At the end of their chemotherapy, 75% were judged to be eligible for a breast conserving approach. Now, not all of those patients chose breast conservation, only 68% did, and breast conservation was successful in 93% of those. So overall, we avoided mastectomy in almost half of patients and potentially could have avoided it in close to 3/4 of patients. So the key thing to remember about lumpectomy after neoadjuvant chemotherapy is that you do not need to remove the entire area of breast tissue that was occupied by the tumor initially. And that's illustrated in this retrospective study from the MD Anderson Cancer Center, where they compared 150 patients having neoadjuvant chemotherapy to 91 who had adjuvant chemotherapy. You can see that the tumors were not significantly different in size pre-treatment, but the amount of breast resected in the adjuvant group was twice as high as in the neoadjuvant group. The re-excision rates did not differ, and local control did not differ. So it is not necessary to excise the pre-chemotherapy tumor volume. Similarly, we had concerns about what kind of margin would be required in the setting of neoadjuvant chemotherapy, because we know that sometimes cancer dies in a patchy fashion with residual cancer cells scattered around. So is a bigger margin a better margin in this setting? And to address this question, we retrospectively looked at a group of 586 women who had received neoadjuvant chemotherapy and underwent breast conservation. 69 of them had a margin that was 2 millimeters or less. The remainder had a bigger margin, and there was a pathologic complete response in 31% or 183 patients. And if we look here at the 4-year rates of local recurrence, you see that the curves are overlapping for the margins that are less than or equal to 2 millimeters or greater than 2 millimeters, and that in fact, the highest rate of local control was seen in the group who achieved PCR, where the 4-year in-breast recurrence rate was only 0.8% compared to 3 to 3.5% in the other groups, illustrating the fact that it's the response to neoadjuvant chemotherapy, not margin width, which determines the risk of local regional recurrence. So if we then think about management of the axilla in the setting of neoadjuvant chemotherapy, we know that the performance characteristics of sentinel node biopsy in patients who start out clinically node negative and remain node negative through neoadjuvant chemotherapy are the same as those seen when you do primary sentinel node surgery, and this should be considered standard practice. So the real question has been, is sentinel node biopsy accurate in patients who start out node positive and downstage to node negative with chemotherapy? Now, there have been 4 prospective multi-institutional trials that have addressed the question of the accuracy of sentinel node biopsy in this setting. Although their inclusion criteria differed somewhat, they were basically studies of patients with T1 to T3 N1 disease. And what you see is that if you look overall at the false negative rate of sentinel node mapping in these studies, it exceeds the 10% level that we have considered acceptable in the preoperative setting. But if we look a little bit more closely, what we see is that technical modifications can change that. The use of dual agent mapping with radiocolloid and blue dye reduces the false negative rate significantly compared to single agent mapping, regardless of what that single agent is. And the false negative rate is significantly lowered when 3 or more negative sentinel nodes are retrieved. So here's a meta-analysis that includes those prospective trials as well as some retrospective literature looking at the false negative rate of sentinel node biopsy in patients who downstage with neoadjuvant chemotherapy based on the number of nodes retrieved. If you have only 1 negative sentinel node, it's 20%. With 2, it drops to 12%. And with 3 or more negative sentinel nodes, it drops to 4%. So if we ask the question, how often is axillary dissection avoided with neoadjuvant chemotherapy if you have to obtain 3 or more sentinel nodes and you need a nodal pathologic complete response? That is the study I'm showing you here that we did with 630 consecutive biopsy-proven node-positive breast cancers who got chemotherapy. 91% of them converted to clinically node negative and were felt to be eligible for sentinel node biopsy. Of those 573 patients, we identified 3 or more negative sentinel nodes in 531, or 93%, and PCR was achieved in 45%. So the net result was we avoided axillary dissection in 41% of patients who became clinically node negative after neoadjuvant chemotherapy. As you would expect, the likelihood of avoiding axillary dissection was strongly correlated with ER, PR, and HER2 status, ranging from 20% nodal PCR rates in hormone receptor positive HER2 negative patients to 78% nodal PCR rates in the hormone receptor negative HER2 positive patients who received dual HER2 blockade. So in the setting of neoadjuvant chemotherapy, does clipping the positive node decrease the false negative rate of sentinel node biopsy? And that suggestion was brought to us from this retrospective study at the MD Anderson, in which they compared removing sentinel nodes only to removing clip nodes alone, or the combination of both, which they called targeted axillary dissection, or TAD. And they found that the false negative rate of sentinel node biopsy alone was about 8%. If you just took out the clip node, it was about 4%. And if you took out both, it was 2.5%. But the thing that alarmed many people in this study was that the clip node, that is a node that contained a metastasis, was not a sentinel node in 23% of cases. And since that time, there have been multiple other studies looking at how often clip nodes are sentinel nodes, and they're summarized on this table. And what you see that anywhere from 65% of the time, the clip node is the sentinel node, to about 81% of the time in these studies. But notice also that the majority of these studies did not use dual mapping, which, as I've shown you, reduces the false negative rate of sentinel node biopsy. And the median number of sentinel nodes retrieved in many of these studies was less than 3. So we did a study at Memorial Sloan Kettering, which I will show you now, in which we looked at 251 patients who came to us with clips in their nodes, because we don't put clips in nodes, and had neoadjuvant chemotherapy and had a sentinel node biopsy using standardized technique of dual tracers with radioactivity and isosulfan blue dye, and had 3 or more sentinel nodes retrieved. We found that in that circumstance, the clip node was the sentinel node 88% of the time, and that in an additional 5% of patients, there was a metastasis in a sentinel node, so we did an axillary dissection, and the clip node came out in the axillary dissection, meaning that without localizing clips, we retrieved them with proper sentinel node technique 93% of the time. There were 18 patients who had 3 or more negative sentinel nodes. Their clip was not identified in the sentinel node. They did not have an axillary dissection, and to date, none of these patients have experienced an axillary failure. But we're focusing here on false negative rates when what we really need to focus on is patient outcomes. So we looked at the outcome of 234 consecutive node positive patients who downstaged to node negative, were treated, as I told you, with dual tracer mapping retrieval of 3 or more negative sentinel nodes, and no axillary dissection. And at a median follow-up of 40 months, there were no nodal recurrences in the patients who received radiotherapy and 1 in a patient who refused whole breast irradiation. Similar findings from the European Institute of Oncology in a series of 123 patients who were only mapped with technetium, only had a median of 2 sentinel nodes removed after neoadjuvant chemotherapy, and in spite of that, at a follow-up of 9.2 years, the 10-year rate of nodal recurrence was only 2%. So outcomes of sentinel node biopsy after neoadjuvant chemotherapy in node-positive patients who downstage are excellent without clipping or localizing nodes, which is much more cost-effective and much less inconvenient for patients. So another interesting observation that we made is related to the risk of lymphedema in patients undergoing neoadjuvant chemotherapy followed by axillary dissection versus those who have upfront surgery and axillary dissection and then get chemotherapy. And this is a prospective study of lymphedema led by my colleague Andrea Barrio, where all patients had baseline arm measurements and then follow-up arm measurements every 6 months. And you see here on these curves that at 2 years, the rate of lymphedema in the upfront surgery group was 11%. In the neoadjuvant chemotherapy group, it was 31%. And in multivariable analysis, after adjusting for things like the number of lymph nodes involved with disease, body mass index, neoadjuvant chemotherapy remained an independent risk factor for the development of lymphedema, increasing it about 2-fold. So this emphasizes that we need alternative strategies to axillary dissection for patients who fail to achieve nodal PCR with neoadjuvant chemotherapy. And the one that has been proposed by many people is radiotherapy. After all, in the upfront surgical setting, as in Amorose and Odoasar, we give radiotherapy to patients with positive sentinel nodes, and the outcome is the same as it is with axillary dissection. So why can't we just do that in the neoadjuvant setting? And there is a very good reason why we need to be careful about extrapolating these results, and it relates to the nodal burden in patients who have neoadjuvant chemotherapy. So here we see the axillary dissection arms from Z11, Amorose, and Odoasar, the upfront surgery trials, where you see that anywhere from 27% to 39% of patients had nodal disease left behind, which was controlled with radiotherapy in the case of these 2 studies. In contrast, if we look at patients who have positive sentinel nodes after neoadjuvant chemotherapy who go on to axillary dissection, both in our institutional series and in the ACOSOG Z1071 study, you see that there is a much higher tumor burden in the axilla, and whether or not this will be effectively controlled with radiotherapy is uncertain at this point in time. So there are 2 prospective randomized trials that are evaluating this question. The Alliance trial has closed to accrual. It randomizes patients who have residual nodal disease after neoadjuvant chemotherapy to axillary dissection plus nodal irradiation versus no more axillary surgery and nodal irradiation. The Taxus trial has a similar design, although it randomizes patients with residual positive nodes to undergo an axillary dissection or to have a sentinel node biopsy plus removal of all palpable abnormal nodes, which many of us would consider a sentinel node biopsy anyway. And then regional irradiation is given to both arms. So we await the results of these studies to see whether or not this is an appropriate approach. In the absence of information from these trials, radiation as a substitute for axillary dissection after neoadjuvant chemotherapy cannot be considered standard at this point in time. So, as I told you, The unifying theme of these trials, which I've just showed you, is that we can control subclinical microscopic disease in the breast and the axilla with less surgery. And if that's true, what's next? And a question that everybody's starting to ask is whether or not sentinel node biopsy is really necessary in 2022. And in thinking about this, there are three things to consider. Does it contribute to survival? Is it necessary for local control? And does it help us determine therapy? So if we look at the survival question, that was asked and answered about 30 years ago now in the classic NSABP B04 trial, where clinically node-negative women were randomized to radical mastectomy or total mastectomy alone, or total mastectomy plus RT, and with 25 years of follow-up, there was no survival difference between these arms, in spite of the fact that these patients did not get systemic therapy. More recently, we have seen that radical axillary surgery does not improve survival in both the ACOSOG Z11 and the AMAROS trial. So we have to put survival behind us. What about local control? So to worry about local control, you have to have nodal metastases. So the first question to ask is, what's the risk of axillary nodal metastases simply with a negative physical exam? So here are two studies from our institution. The first had 5,300 patients, T1 to T3 tumors, any menopausal status. Only 19% of patients had macrometastases, and only 6% had more than 2 involved lymph nodes. In a study of 3,300 patients with T1 and T2 tumors who were all postmenopausal, macrometastases in 23%, N2 or 3 disease in only 3.6%. And if we look a little bit more closely in that postmenopausal subset about factors predicting a heavy nodal disease burden, notice that ER, PR, and HER2 status were not predictors of N2 or N3 disease. It was the same across all of those groups. What did predict N2 or N3 disease are things that we would expect: younger postmenopausal age, lymphovascular invasion, multicentric disease, and bigger cancers. So there are now 3 clinical trials asking the question of whether you can avoid sentinel node biopsy in patients with a normal physical exam and a normal axillary ultrasound. And that's the SOUND, the NCEMA, and the BOOG 2013 8 trial. SOUND includes only T1 tumors. The other 2 studies include T1 and T2. And they have different endpoints of distant disease-free survival, invasive disease-free survival, or regional recurrence. These endpoints are not yet available, but we can get an idea of what they're going to be by looking at the early reports from 2 of the trials. First, notice that although these trials are open to women of any age, they are overwhelmingly studies of postmenopausal women with hormone receptor positive cancer. You see that the incidence of macrometastases ranges from 8.6% to 14%, the likelihood of 3 or more positive nodes from 0.5% to 1.3%. So not very likely. And how common is nodal recurrence in the absence of axillary surgery? That question was asked many years ago now in the IBCSG 1093 trial, which was a trial of postmenopausal women. 42% of them had tumors larger than 2 centimeters in size, and only 1/3 of them received any radiotherapy. And in spite of that, at a median follow-up of 6.6 years, there was no difference in axillary first events between those randomized to axillary dissection or no axillary dissection. So I think what we can conclude is that most clinically node-negative patients with physical exam, with or without ultrasound, do not have a heavy nodal disease burden, but between 9 and 23% will have 1 or 2 nodal metastases. So then we have to ask, in the era of personalized medicine, does the presence of nodal involvement or the number of nodal metastases change adjuvant therapy? So if we look at nodal status and systemic therapy, we see that for HER2 overexpressing cancers, the chemotherapy backbone and the use of dual HER2 blockade are highly dependent upon nodal status. So nodes matter in HER2 positive breast cancers. In triple negative breast cancers, nodal metastases are an indication for pembrolizumab, so nodes matter here. But if we look at the more common hormone receptor positive HER2 negative cancers, in premenopausal women, node positive women get chemotherapy. In node negative women, it's determined by the Oncotype score. But in postmenopausal women, we see that whether you're node negative or you have 1 to 3 involved nodes, it's the Oncotype score that determines chemotherapy use. And that's, of course, based on the findings of Taylor-X and R-Exponder, which show that in postmenopausal women who are node negative or node positive, the addition of chemotherapy to those with recurrence scores under 25 does not improve outcome. So recurrence score determines chemotherapy need in both node negative and node positive postmenopausal women based on the findings of R-Exponder, but R-Exponder included only patients with 1 to 3 involved nodes. So do we need to do an axillary dissection on all sentinel node positive patients to see how many nodes they have? And if we look at R-Exponder, you see that patients with sentinel node biopsy only were eligible for this trial. And in fact, they made up 37% of the enrolled patients. And if we look at this forest plot for factors predicting chemotherapy benefit in postmenopausal women, you see that there's no trend based on the number of involved lymph nodes or whether the patient had a sentinel node biopsy or an axillary dissection. So what I would conclude from this is that involvement of 4 or more nodes in clinically node negative patients with a normal axillary ultrasound occurs in fewer than 2% of patients. The large number of women with sentinel node biopsy in R-Exponder provides reassurance that chemotherapy benefit was not seen to trend in this group, and there was no trend for chemotherapy benefit as the number of involved nodes increased. So I would say overall, there is an unfavorable risk-benefit ratio for axillary dissection in this setting. So what about radiation decision-making? Nodal status is the major determinant of the use of regional node radiation after breast conservation therapy and of post-mastectomy radiotherapy. It's also part of decision-making for partial breast irradiation. And while we can feel comfortable that heavy nodal disease burden is not present in patients with a normal physical exam and a negative axillary ultrasound, 7 to 14% of those patients will have macrometastases in 1 or 2 nodes. So we retrospectively looked at the impact of nodal status on decision-making in the postmenopausal hormone receptor positive HER2 negative subset of interest. There were 1,700 patients clinically T1, 2, and 0, hormone receptor positive HER2 negative. We looked at how often axillary dissection came about based on the finding of 3 or more positive nodes. We looked at suitability for partial breast irradiation based on the ASTRO criteria. We looked at regional node irradiation based on the algorithm I showed you previously that we use here. And we looked at how often patients would need chemotherapy because they were N2 or N3. And so what we found was that the finding of a sentinel node biopsy in 1,786 patients resulted in 20 axillary dissections, or a 1% change. It led to regional node irradiation in 58 patients, or 3%, and it led to chemotherapy for N2 or N3 disease in 17 patients, or 1%. The biggest impact was on eligibility for partial breast irradiation, which decreased by 13% based on the findings of sentinel node biopsy. So relatively small changes. So I think what we can say is that in postmenopausal hormone receptor positive, HER2 negative, clinically node negative patients, axillary staging rarely changes the systemic therapy approach. Ongoing trials attempting to refine the use of nodal RT and PMRT in biologically low-risk women may further decrease the importance of nodal status in radiation decision-making. But until that time, sentinel node biopsy is certainly less morbid and less costly than giving regional node irradiation or PMRT because of uncertainty about nodal status. So in conclusion, enormous progress in tailoring breast and axillary surgery to the extent of disease has been made, which has reduced the burden of treatment for patients. Decision-making in breast cancer has become increasingly complicated and really requires a multidisciplinary approach to achieve maximum benefit. And breast surgery is alive and well and remains the most evidence-based of the surgical disciplines. I will leave you with the thought that the genomic era offers the opportunity for avoidance of axillary surgery in a significant number of breast cancer patients, but requires acceptance of a greater amount of uncertainty than physicians have historically been comfortable with. I thank you for your attention. And again, I'm sorry I couldn't be with you today. Thank you.
Thank you, Professor Monica Morrow, for giving us an extensive and elaborative evidence behind de-escalation of breast surgery from maximally tolerated to minimally effective. Just want to check if we have Professor Morrow online.
Yes.
Can you hear us, Professor Morrow?
I can hear you just fine. Can you hear me? Can you hear me?
Yes, we can. Thank you, Prof. Morrow, for joining us at such early hours of the morning there in New York. Traditionally speaking, we do not take question answers at the end of our plenary session. So I would request you for very brief concluding remarks before we conclude this session. Thank you.
Thank you. Well, I think this is a very exciting breast cancer. And I think that as surgeons, we need to continue to do is to try and leverage the improved systemic therapies that we're seeing to perform less surgery in patients who are good responders, without giving up aggressive surgery in patients who have a poor response who will benefit from local control. And I think finding that balance is the challenge.
Thank you. Thank you so much for joining us and giving us your presentation.
Thank you for the opportunity to participate.
Thank you. So towards the end, thank you. Towards the end, I would like to thank you all for joining us in person or virtually. I hope you enjoy the rest of the symposium very much and wish you all a very good evening. Thank you.